Hello everyone. Today we discuss about the immunotherapy in cancer. I am Dr. Balkishan Gehlot. We discuss about the mechanism and the checkpoint, what are the agent and dosing, and what are the toxicity management. Basically, we presentation as a outline, foundation of the cancer immunology, what are the mechanism, checkpoint and receptor, type of immunology, agent, dose, infusion, administration, what are the pseudo progression, and what are the response pattern of immune therapy, what are the baseline evolution before we starting the therapy, and immune related toxicity and the grading according to CTCA, and management of toxicity according to NCCN, ESMO and the ASCO guidelines. So we started with foundation of cancer immunology first. What are the foundations of cancer immunology? What are the immune therapy? First at all, we know about that radiation and chemotherapy are directly killing the cells because that act directly on the cancer cell. But in immunotherapy, first at all, immune agent change the immune system to recognize and destroy the cell. So they first at all restore that immune system. Second, they given the durable response. Why there is durable response? When we activate our immune system, it create as a memory inside. So that is given as a durable response. There are the fourth pillar. After the surgery, chemotherapy and radiation, there is the fourth pillar for treating the cancer patients. We know about the brief history. First in 1891 started with Cooley's toxin. So Cooley's toxin made by the scientist, his name is William Bradley Cooley. And what is the Cooley's toxin? It is a heat-killed bacterial toxin which is made by the two bacteria. Okay. So what are the basic reason behind that is it create the high-grade fever and create a strong immune response. So that are the basic reason behind this Cooley's toxin. So after make a Cooley's toxin in 1891, continuously increase and change day by day. In 2011, ipilimumab that is made. In 2018, Nobel Prize of Medicine goes to James Allison and Tasuku Honja for the development of the checkpoint inhibitor CTLA4 and the PD-L1 agents. Okay. So after that you know about the basic of history of immune therapy. So we started with there are the two type of immunity in our body. One is to be innate immunity and one is to be adaptive immunity. What are the basic difference is between that? You show that major difference is to be key cell. One is to be in innate immunity, that is to be macrophage, NK cell and dendritic cell is our main cell. In adaptive immunity, T lymphocyte and the B lymphocyte is the major cell. Innate immunity make a initial response and show that antigen presentation. That is very important in immunology of the tumors. Second is to be adaptive, that is by the T and B cell, that is are used as a target tumor cell killing. Adaptive immunity is a highly antigenic specific, and second, it is a very long life memory. In innate immunity, there is no memory and that is a known specific. It just recognize the antigen. Okay. So what are the key player in the anti-tumor immunity? First is our dendritic cell. What is the dendritic cell? It is a type of cell which is capture this antigen and presenting this antigen to T cell. Which type of the T cell is to be CD4 type of the T cell, and is act as a bridge between innate immunity and the adaptive immunity. Okay, second is to be CD8 cell, that is called the cytotoxic T cell. CD8 cell directly recognize the cell which is showing MSC class 1 molecule. Okay, one is to be NK cell which is not needed of the MSC, so it is act as the low MSC tumor. Why is to be act? It is killing the stressed cell. So already tumor cell having the O2 level very low due to very fast growing, so that is stressed cell and that is killing by this NK cell. There is a 3 type of the cell which is used in measure anti-tumor immunity. Okay, what is antigen presentation? Antigen presentation is decided by that one is to be by the MSC class 1. MSC class 1 molecule that is expressed on the all nucleated cells. Okay, when any nucleated cell which having the MSC class 1 and that is infected by the any virus and the any antigen or the any tumor antigen which is presented to CD8 of type of the cytotoxic cell, and that cell kill this. Okay, and second, if the MSC class 2 is to be used, this is used when the dendritic cell capture this outer side antigen and make as a peptide MSC complex, and this complex is presented to CD4 type of the helper cell and that act. And the third important mechanism is to be priming, and that is also known as a co-stimulation. When CD4 cell which is presented in the lymph node, okay, this lymph node CD4 cell, the dendritic cell presented antigen to this CD4 cell. Okay, when this CD4 cell is to be presented antigen by the dendritic cell and that is to be activated. Okay, but the final activation needed this co-stimulation, or this is processing known as a priming. And what is this co-stimulation and how is to be going on, we discuss is about the later. Okay, so this is the basic mechanism behind that MSC class 1 and 2. When MSC class 1 which is presented on the all nucleated cell like viral protein, that is to be infected cell. Okay, this infected cell directly present this viral or tumor protein as a endogenous peptide to the CD8 type of the cell. This viral protein or the tumor protein that is inside of this infected cell, this infected cell this make as a endogenous peptide and this presented to this CD8 cell, and this CD8 cytotoxic cell kill this infected cell. And in MSC class 2, first APC antigen presenting cell, that is called the dendritic cell, which capture this antigen and after that is make as a antigen peptide complex, MSC complex. This is show as a exogenous peptide and this presented to CD4 cell, and then CD4 helper cell is to be kill this antigen. So that is the basic difference between MSC class 1 and MSC class 2. Okay, and what is the different type of the tumor antigen and what will be happen about that? Tumor antigen, that is a mostly 3 type of the antigen which is shown by the tumor. One is to be TAA, that is called the tumor associated antigen. So this antigen normally presented in tumor cell, but that also presented into the normal tissue also, that is called tumor associated. So HER2 and the MART1, this type of the antigen. Second antigen is a tumor specific antigen, that's like name is to be suggest that is a unique and specific for the tumor only. That is example is like viral oncoprotein HPV driven cancer. And what are the HPV driven cancer? One is to be cervix cancer, vulva vagina, penile cancer, anal canal cancer, and oral cavities cancer. Okay, third is to be neoantigen. What is the neoantigen? during the disease or during the treatment and during disease progression, there are some somatic mutation also developed, that is called the neoantigen. When the mutation burden is to be high, that means the somatic mutation production is to be very high, that is called the tumor mutation burden, TMB. When this tumor mutation burden is more than 10 mutation per megabase pair, that is called the high tumor mutation burden, and this is also as a condition by which the immune therapy work more. So that known as a somatic antigen. So there is a 3 type of the tumor antigen will be presented. How antigen presentation activate the immunity, we previously discussed. When the dendritic cell is capture this antigen and presenting to CD4 cell, and the CD8 cell directly presenting this antigen by the MSC class 1 cells, and NK cell is no needed of the MSCs. Okay, so in our body there is a basic immunity cycle is to be going on, and what will be happen in this cycle? First at all, when any tumor which is released that our antigen, dendritic cell capture this antigen, and dendritic cell present this to T cell, and T cell is to be activate and the priming also, and then T cell trafficking toward the tumor, and T cell infiltrate the tumor, and then T cell recognize this tumor cell and the killing of the cell. So there is a normal immunity cycle, but this cycle is to be evaded by the tumor cells. Okay, and what will be happen about that? We discussed that how to tumor evade this immunity. First at all, checkpoint up regulation. As a checkpoint level, PD-L1 and the other ligand which is presented on the tumor, they are masking the PD-1 which is presented on the T cell. So T cell is to be switch off. Second is to be micro environment. Most of time, like the some cytokinin which is example like tumor growth factor beta is dampen the response of the immune cell. And third is to be antigen loss or the MSC down regulation. That is also a reason for that tumor is not to be recognized as foreign antigen. So this is also a reason. So how does cancer cell escape this immune surveillance? So what will be happen at that level? First at all, if antigen visibility is low, it means antigen loss or the mutation make the tumor cell hide. Second, MSC visibility. If the MSC is to be low, so that also as a cause of tumor cell escape that immune system. Third is to be checkpoint signal. If the PD-L1 expression on the tumor cell, and shall be local suppression of environment like the tumor growth factor beta and the some other cytokinin. So in that situation, tumor is to be survive, tumor is to be growth and metastatically spreads. So what will our target? Our target is to be avoid this type of the mechanism or situation. So what are the mechanism of the checkpoint and the other receptors? So immune checkpoint reprogram the T cell response, and how it is to be happen? This happen when the T cell how is to be happen when we using the PD-L1 or the PD-1 receptor antagonist, so that is reduce or inhibitory signal that is to be removed and the T cell is to be functionable. When we using the CTLA4, so we change the priming complex and that increase the T cell priming. And one is to be LAG3 which is also act by the MSC class second. So if we using the leg inhibitor, so MSC class second is working very well, and this is also reprogram the tumor cell, and how all the things is to be happen by the drugs. Okay, so there is a two signal during the activations of the T cell. First at all, first signal is to be that antigen, which antigen make as a antigen peptide MSC complex which is presented to T cell, and the T cell is to be activation. Second, we know about the co-stimulation, in which the one molecule is called the CD28, which is on T cell, that bind to CD80 and 86, and that is our license to full activations of T cell. And third is to be some cytokinin like interleukin 2 and the other some cytokinin, which is help to make the micro environment good. So you don't confuse some cytokinin like tumor growth factor beta, which is create the negative microenvironment, and the some cytokinin like interleukin 2, interferons alpha, that is make the good environment for the tumor killing. Okay, so what is the co-stimulation and co-inhibition? So co-stimulation is to be done by the CD28 and ICOS OX40 41BB, and co-inhibitor by the CTLA4, PDL1, LAG3 and the TIM. Okay, that is the basic thing. So what are the CTLA4 biology? We discuss about that. One thing is very important about this, CD28, okay, that is presented on the T cell. This bind to B7 ligand, that is also known as a CD80 or the 86. Okay, when this CD8 of the T cell bind to this B7 ligand, full activations of T cell is to be happen. But this CTLA4 act as a competitive inhibitor of this CD28, so it bind to B7 ligand, so that CD28 is not bind to this B7 ligand, so that co-activation or the priming phase is to be hamper. So we using the CTLA4 inhibitor. Okay, so when we using the CTLA4 inhibitor, this CTLA4 anti-CTLA4 antibody, when we using this antibody, it masking this CTLA4 antibody. So CD28 now free, so it is not having any inhibitor. So CD28 is bind to B7 ligand, and co-activations of the T cell is to be happen, and full activations of T cell will to be happen. One of the agent is known as a ipilimumab, okay, which is used as a CTLA4 inhibitors. Okay, second is to be PD1 or the PDL1 biology. Okay, you know that they are the very similar. What you know that about PDL1 and PDL2, that is presented on the tumor or the stromal cell, and PD1 is to be presented on the T cell. When the PDL1 or L2 bind with PD1, that are switch off the T cell, because T cell recognize as a tumor cell as a self cell. So we blocking either PD1 or the either PDL1 or L2. So this masking is to be happen, and the T cell recognize this tumor cell as a foreign cell, and the killing is to be started. So this is as a basic mechanism for the PDL1 L2 or the PD1. So this is create the reactivation. So what are the example of this agent? So PD1 agent is to be pembrolizumab, nivolumab, cemiplimab, and the PDL1 agent is to be atezolizumab, durvalumab, and avelumab. Okay. Some emerging checkpoint inhibitor also that we discuss about that, LAG3. LAG3 also act by the MSC class second. So it is make as a complex with them and inhibit the T cell mechanism. When we using the LAG3 inhibitors, so free MSC class second is to be available, and that act for immune system, and this is used for the melanoma. Some other emerging agent like that, TIM3 inhibitor and TGATE. TGATE did co-stimulatory for CD226, but that trial is to be going on. So that is under some receptor, ligand and the site of action. We know about that only CTLA4 is to be act in lymph node. All other PD1, PDL1, LAG3 that is act on tumor. Okay, that you know about that. Okay, how checkpoint inhibitor work? We discuss is to be one by one step. So if you using the any target therapy, any immune therapy, first we know about that what are the indication and how is to be work, and which receptor you doing for suggested that is to be working or not. So we using the three predictive biomarker. What is the biomarker? There is a two type of biomarker. One is to be predictive biomarker. That means you know about that. Predictive biomarker means which type of biomarker which is used prognosis and as well as therapy, and one is to be only prognostic biomarker. Okay, prognostic biomarker means that biomarker will show only prognosis. So we use as a predictive biomarker three type of the biomarker will be used. One is to be PDL1, one is to be MSI, and one is to be TMB. Okay, so first at all we discuss about the MSI. MSI, that is called the microsatellite instability. This means that is a in nucleus. So in DNA it is microsatellite instability. If this microsatellite instability, it MSI will be high. It means so mutation is are more. So called the tumor mutation burden high when the 10 mutation per mega base pair. So when the DNA show high MSI, that is create the more somatic mutations. When the somatic mutation is to be more, that means neo antigen is to be more produced. So if more neo antigen is to be produced, then more PDL1 expression. So that are the interconnected to each other. So they biomarker uses for treating the therapy as PDL1 or the checkpoint inhibitor. And one important tool, MSI and tumor mutation burden is our tissue agonist. What is the tissue agonist? It means this type of the marker which is not dependent upon the tissue biology. If this type of marker is to be present, then we using the immune therapy. That is called the tumor agonist biomarker. So this is the basic mechanism. We read already this. So what will be happen if the MSI high in the nucleus? That means if the high MSI in cancer cell, that means you using the high tumor mutation burden or the high new antigen is to be produced. If the the tumor mutation burden is to be high, then is more presented PDL1. So immune therapy is to be working in this type of situation. Okay, so we using first at all we know about the how will PDL1 is to be tested. So there are many ISC based assay in we using the ISC for detect this this type of immune therapy. So we using to detect how is to be working and what is the PDL1 level. So we using the ISC. Okay, in ISC they using the many type of the probe. One is to be 22C, 28A, SP263, SP142 and 7310 assay. Okay, so this is the type of assay using the different type of the score. One is to like TPS, CPS, IC score and that all. And this every IEC probe is to be specific for drug, like the 22C3 is to be specific for pembrolizumab use, 28-8 is to be used for nivolumab, SP263 is used for atezolizumab. So there is a different type of the probe by which we using the ISC. Okay, what are the different type of score? One is to be TPS score. Okay, so what will be TPS score and what is the CPS score and what is the TAPE score? So TPS score means the tumor proportional score. So how many tumor cell show that PDL1 positivity along the total viable tumor cell. So this is count as a that is cutoff is 1% and 50%, that used in non-small cell of the lung cancer. So previously this is to be uses for urothelial cancer also, but now is to be absolute for urothelial cancer. Okay, so second is to be CPS score, that is the combined positivity score. Combined means PDL1 positive tumor cell as well as PDL1 positive infiltrating lymphocyte and macrophage, that is called tumor plus immune cell. This is as a cutoff is 1, 10, 20, that is used in gastric cancer, cervical cancer, head and neck cancer and esophageal cancer. Third is to be TAPE, is called tumor area positivity. That means this using the how much part of the tumor cell, how much part of the tumor percentage we show that PDL1 positive. But nowadays TAPE is to be absolutely not used. So, and one important score is called the IC score, that is immune cell. In TPS we using only tumor cell. In CPS we using the tumor cell as well as immune cell. But in IC that is using only immune cells. So this is used now as in urothelial cancer and selected breast cancer, and which is the probe is to be used SP142. So what is the type of immune therapy? Classification of immune therapy is based on the passive, active and immunomodulative. What is the passive? In passive, directly infuse the effector cells like as monoclonal antibody and adaptive cell therapy like CAR T cell therapy and some other genetic engineering cell therapy. And the active means that stimulate the patient immune response like the vaccine and cytokine. And immunomodulator, that is type of the drug which release the inhibitory signal. So our checkpoint inhibitor under this category, immunomodulator. So immune checkpoint used as a CTLA4, PD1, PDL1 and LAG3, uses in melanoma, lung, renal, bladder, head and neck and so many cancers. So one is to be cytokinin therapy we discuss, that is called the active immunity. Cytokinin, that is high dose interleukin 2 and the interferon alpha. There are two type of the cytokinin which is previously uses in melanoma. Okay, so now it is to be applied, and interferon alpha also uses in some hematological malignancy like in CML before we using the imatinib and that all hydroxyurea urea and the interferon alpha, that is used in hematological malignancy. What are the limitations of this is that is very severe and the significant systemic toxicity will be there. So one is to be cancer vaccine. We two type of the cancer vaccine usage. One is to be preventive cancer vaccine and one is to be therapeutic cancer vaccine. Preventive like HPV and the hepatitis B, and therapeutically used in the like metastatic CA prostate. Okay, and the many mRNA vaccine is are under trial. So cancer vaccine we using as a separate class for cancer vaccines. Okay, one is to be oncolytic virus therapy. One important and the very good virus is to be T-VAC, that is a modified herpes virus which is used in unresectable melanoma. One is to be genetic engineering cell. One is to be TIL, that is called the tumor infiltrating lymphocyte. This tumor infiltrating lymphocyte is extract from the tumor and make it as a genetic engineering changes and reuse in the patient. One is to be TCRT, that is the T cell receptor engineering according to the targeted antigen. So this type of therapy is also used. One is to be CAR T cell therapy, that is called chimeric antigen receptor to recognize the surface antigen. One very important thing for CAR T cell therapy, it is independent of MSC, because that surface antigen of the CAR T cell therapy ideally changed by the genetic engineering, so it is not required this MSC. Okay, so there are basic target is to be CD19 and BCMA, And some example of like that, execabatazine and the other. One important side effect is called the cytokinin releasing syndrome, and one is to be neurotoxicity. So one important thing is to be bispecific T cell. Bispecific T cell means this type of the T cell using the one arm is bind to CD3 on the T cell and another on the tumor antigen, like belantamab and some other agent. We discuss about all in the separate classes. So other modality is to be necked monoclonal antibody like the rituximab, trastuzumab, which is used, and the antibody drug conjugated like TDM1 and some other combined therapy. So what is the agent, how the dose, and what is the infusion, what is the admission? This section is to be only readable section. Okay. So one is to be pembrolizumab, use as a flat dosage 200 and the 400, and that is the 30 minute of the infusion. Final concentration is to be make as 1 to 10 milligram per ml, and that is always given in NaCl or the dextrose solutions. Okay. Second is to be nivolumab. Nivolumab also uses as a 240 and 480, and previously is uses as a weight basis molecule 3 mg per kg in the older regimen, that is also using in the NaCl and the dextrose solution. And third is cimiplimab, and cimiplimab mostly uses skin cancers mostly, and that is also having the 30-minute infusion 350 mg flat dose, and also given in NaCl and dextrose. So other is atezolizumab, and atezolizumab used as a flat dose of the 1200. Do not use with dextrose, that is very important about the atezolizumab. So only NaCl is to be uses. Okay. And third is to be durvalumab, and durvalumab that is used 1500 flat dose as a current condition, but previously used as a 10 mg per kg in older regime, also used in NaCl and the dextrose. And avelumab, that is very important. Most of immune therapy is not giving the not using with pre-medication because they are not having the hypersensitivity action, but avelumab is a drug which is used with pre-medication. So first 4 infusion is used with pre-medication, and avelumab having the 800 mg flat doses. Okay. So one important is ipilimumab, that is a CTLA4 inhibitor. Okay. And that is the 3 mg per kg dose in melanoma, and if 1 mg per kg in combination and 10 mg per kg when using the adjuvant, we also using NaCl and the dextrose solution for that. And one is to be tremelimumab, that is another CTLA4 agent, so used in the hepatocellular carcinoma, 300 mg dose in SCC and 75 in non-small cell lung cancer. One important LAG3 inhibitor, that is called the relatlimab with nivolumab, that is used in treatment of melanoma, that is used 160 mg with nivolumab 480 mg. Okay. So one ipilimumab and nivolumab combination, that is used in the melanoma. So pre-medication, mostly in immune therapy we not recommendation the pre-medication, but in avelumab first 4 cycle using pre-medications. Okay. So in view of the administration, that is important for nursing staff and the old doctors. In view of administration, first at all, we using the baseline lab and the organ function before each cycle, using a in-filter as specified per agent. Never administration as IV push or the bolus, and do not co-infuse with any other medication in the same line. Observe the patient during and after the first infusion always. That is very important when we using the immune therapy. So what are the pseudo progression, what are the response pattern? That is the in immune therapy the response pattern is not like that chemotherapy. First at all, this is showing the delayed response because response may appear after the survival cycle. Second, that is doing the durable response because is create the memory, and one is to be atypical response, that is initially growth or the new lesion before regression of tumor. So what are the different type of the response? We discuss about that. One is to be pseudo progression. How is to be then? When T cell activate and infiltrating in the tumor cells. So this is create act like as a tumor is to be progression. So that is called the pseudo progression. So that is early or as well as delayed, both type of the pseudo progression. And if the patient is to be clinically stable, then continue, start the therapy and repeat imaging. Okay, so how we know this progression is to be pseudo progression or this is to be as a true progression? So when using the pseudo progression, patient is to be clinically stable or improved. When true progression, patient is deteriorated. Second, in pseudo progression, continuously lesion is to be shrink in sequencing repeated scan, but in true progression this is to be continuously grow. So pseudo progression continue and the reimaging continue the therapy, but if the true progression, then switch the therapies. Okay, so hyper progression, this is type a condition which is a marked increase in the growth, so that is happen in older age, higher mutation burden and the certain genomic alternation. So we discuss about in CA lung hyper progression also. So I resist. Okay, this is the resist criteria for the immune therapy, and that is very different from the chemotherapy, which is the one is to be IUPD, that is unconfirmed progression. If the unconfirmed progression, the treatment is to be going on. If ICPD, that is confirmed progression on the next scan, which is done by 4 to 8 weeks later. So purpose to avoid the stopping of the effective therapy, we using this I resist criteria. So what are the baseline evolution before the therapy? So how it to be help? One important is to be detect the risk, because if the autoimmune or the organ dysfunction, so act as a reference fault and patient counseling also about the unexpected or the warning symptoms. Okay, so mandatory lab work is to be during that therapy. One is hematologically, that is fresh blood count and the differential count, biochemical LFT, RFT, urea, create LDS and that all, endocrino TSH, free T for glucose, cortisol and HB1AC, and virology, that is to be HIV, hepatitis B, core antibody, hepatitis C, reproductive serum pregnancy test. Okay. So organ specific is to be in cardiac ECG for all, consider 2D echo if the history of the heart disease, pulmonary baseline oxygen saturation, pulmonary function test DLCO, autoimmune screening for rheumatoid arthritis, lupus, IBD, psoriasis, and pituitary baseline managing the cortisol and ACTS if available. Patient education checklist, and why what to be educated to patient about this. Any new onset of diarrhea, abdominal pain, shortness of breathing, new onset cough, severe skin reaction, blistering, extreme fatigue and persistent headache, unusual thirst and frequency urination, this is called as a patient alert card. Then this is make to patient, and every time patient carry this. Okay, so immune related toxicity and grading, we discuss about that. What is the immune related adverse event? This is happen in any organ, okay, like skin, GI tract, liver, endocrine, but that are the most common organ. So distinct from the chemo, because it is not related to cell count nadir and not mostly that is inflammatory nature. So timeline is occur mostly day to month after the, and mostly is after, sometime is to be after years. Okay, so incidence and timing, if you using as a monotherapy, so most of time 25%, that is when PDL1 and the single. If the CTLA4 using the 25 to 50, so CTLA having show that more toxicity. In combination is occur in 90% of the patient, grade 3 and 4 occur in 55%, that is big 4. First appear rashes week 2 to 4, then colitis 6 to 8 week, and if hepatitis they develop mostly in 8 to 12 week, endocrinopathy, mostly development 12 week after. So what is the grading? That is the basic grading which is using for the all type of the toxicity. So mild toxicity means asymptomatic or the mild symptom, so only observation is to be done. Moderate, that means minimal or local non-invasive intervention, but ADL is to be limited. One is to be severe, that means severe or medically significant but not immediate life threatening. Hospitalization indicated. Life threatening is to be grade 4, that is urgent intervention is to be indicated. So common toxicity, one example like diarrhea. Okay, so in diarrhea, if grade 1, that means less than 4 stool per day or mild increase in osteomy output. Grade 2 is 4 to 6 stool or the moderate increase in osteomy output. Grade 3 is to be 7 or more than 7 stool per day, and incontinence or the hospitalization is to be indicated, and grade 4 is to be life threatening consequence is to be happen. So what are the 5 pillars for management of this immune related adverse events? So first of all, patient education and baseline screening, a high index of suspected for new symptom, detect the lab and the clinical age time, and started the steroid and immunosuppressive as per, and monitor close follow up of this. What are the management? General management, grade and the event of the according to CTCA grading is to be done. First at all, hold of the checkpoint inhibitor if grade 2 and upper, start the steroid of the grade 2 and 3 most of events, and escalate the immunosuppression if the steroid is to be refractory, and rule out the infection other cause before the treating. Okay, so that is are the basic rule. So steroid is to be main backbone to treat this type of the immune therapy related side effect. So in grade 2, prednisolone is orally 0.5 to 1 mg per kg per day. In grade 3 and 4 is to be methylprednisolone, which is using the 1 to 2 mg per kg per day. When the symptom is to be controlled, that is taper gradually in 4 to 6 weeks. Okay, so grade wise management, if grade 1, then continuation of immune therapy is to be done, only supportive care and monitoring. Grade 2, hold this therapy and start the prednisolone. Grade 3, hold or stop, methylprednisolone is to be started. And grade 4, that is always discontinuation and started methylprednisolone and admit. You think that one important thing, if the patient having the pneumotoxicity or the cardiotoxicity, grade 3 and 4, always discontinue the therapy. Otherwise following this, all other toxicity we following this rule. First of all, dermatological toxicity. Grade is according to grade 1, 10% less body area, grade 2, 10 to 30% body area, grade 3, 30 more than 30% or the blistering, and grade 4 is Stevens-Johnson syndrome and toxic epidermo necrolysis. Grade 1 is the topical steroid antihistaminic and continue IC. Grade 2 is topical oral steroid and consider holding, and grade 3 is to be hold ICI, prednisolone will be started, and grade 4, that is permanently discontinue and starting the steroids. Okay, as per then colitis and diarrhea that we discussed about the previously, grade 1, that is 4 stool, and grade 2 4 to 6, and that is grade 3 is more than 7, and grade 4 is to be severe. So in grade 1 only hydration, monitor and continue IC. Grade 2 hold the IC and start the steroid, and grade 3 is methylprednisolone 1 to 2 mg per kg per day, and if the refractory we started the infliximab 5 mg per kg dose. So in hepatitis, that is very important things. Hepatitis we using not using the infliximab. Why not using? Because it is also causes the hepatotoxicity, and second, infliximab reactivate the different type of the hepatitis. So in hepatitis, grade 1 is to be increase enzyme of the upper limit but less than 3, grade 2 3 to 5, and grade 3 to 4 is more than 5. So that are the same thing, but we using the mycophenolate instead of the infliximab. So that is pneumonitis. Pneumonitis, that is grade is to be very important, because grade 1 is to be only radiologically seen, patient having the no symptom. Grade 2, that means the symptomatically. Grade 3 is to be severe, and grade 4, that is patient showing the hypoxia. Okay. Endocrinopathy. If hypothyroidism occur, then we starting the levothyroxine replacement. If hyperthyroidism occur, treating the symptomatically with beta blocker. If hypophysitis adrenal, then we using the hydrocortisone as a replacement. So what is the guideline based toxicity management? If one important is to be cytokinin releasing syndrome. Cytokinin releasing syndrome mostly occur in CAR T cell therapy and that all. So this is happen in 10 to 15 days after the infusion. Okay, so patient showing the fever, hypotension, hypoxia, cardiac hepatitis and the renal dysfunction and all other things. So grading of this CRS is to be done by the American Society of the Transplant and Cellular Therapy called the ASTCT. According to that, this CRS grading is to be dependent on the fever, hypotension and the hypoxia. Grade 1 only temperature will be increased, no hypotension and no hypoxia. Grade 2, third and fourth, that is having the fever, but grade 2 is to be hypotension but is not required the vasopressin, and grade 3 is required one vasopressin, or grade 4 is to be multiple vasopressor is to be required. Hypoxia, grade 1 is no hypoxia, grade 2 is to be low flow nasal cannula, grade 3 is to be high flow nasal cannula, and grade 4 is to be BiPAP and this type of the other things. So what is the CRS management? If the grade 1 is to be done, then sepsis screen, empirical antibiotic, IV fluid, considered the tocilizumab, okay, that is having the interleukin 6 inhibitor, or the dexamethasone as per early onset. Grade 2 tocilizumab or dexamethasone, IV fluid, vasopressin if the refractory of these agent. Grade 3 ICU care, and we using the tocilin and dexamethasone, and dose will be, frequency will be increased. And the grade 4 is to be ICU, ventilation and the tocilizumab, dexamethasone. If refractory, then methylprednisolone will be started. And another important thing is to be the tocilizumab having the maximum 4 dose. Okay. So ICE management. ICE, that means immune effector cell associated encephalopathy. That is a neurotoxicity of the immune checkpoint event. So that is assessment tool is behalf of the doing the numbering. On orientation, giving the 4 number, 1 for year, 1 for month, 1 for city, 1 for hospital. As like naming 3 object, clock, pen and that all. So giving the 3 and following the command, there is a 1 number. For writing is to be 1 number, for attention. According to that, we using the score, maximum is to be 10. Grade according to grade. Grade 1, that means 3 to 6. And grade 0 to 0 to 2, grade 3, and the 0 and unreasonable is to be grade 4. So if the more is to be number, that means less is to be toxicity. Okay. So according to that is our immune effector cell associated neurotoxicity syndrome, that is grading by the ASCT. So we using the scoring system of the ICE, that is 7 to 9, 3 to 6, 0 to 4, and the 0 for unreasonable. Patient is to be conscious, seizure is to be happen, motor or ICB function. Behalf of that, we assessment the neurotoxicity from immunotherapy. So according to this neurotoxicity, we using the different type of the treatment. If the grade 1, that is only supportive care, and consider the dexamethasone 10 mg the single dose. Grade 2 dexamethasone, but repetition is to be BD, and the tocilizumab if the CRS to be on. Grade 3 dexamethasone, but is every 6 hourly, and if the methylprednisolone 1 mg per kg, then every 12 hourly. So grade 4 is to be needed ICU. So one important topic is to be steroid refractively immune therapy related adverse event, like the colitis, hepatitis, pneumonitis, myocarditis. And in hepatitis, we using the mycophenolate. Other side, we using the infliximab, mycophenolate, and this type of the all agent. In neurologically, we use the plasmapheresis, and sometime using the rituximab also. So after the discussion of this thing, some important thing is to be discussed. First at all, we discuss about that if a patient come with LFTD range or the RFTD range. So what will happen? We started the immune therapy or not? So you thought that immune therapy is not excreted or the net not metabolized by that liver or renal. So that is safe any LFT or the any KFT value. But if the previously patient having the high grade of the hepatic failure or the hepatotoxicity, so the symptom is to be frozen by the using of immune therapy. And second important thing is to be happen, send immune therapy and the immune receptor that is are not showing the evenly on the all metastatic side. So sometime we show that we using the immune therapy in the metastatic, some metastatic side is to be regress and some is to be not, because of immune status of the different metastatic side will be different. Okay. And sometime when we using the immune therapy, and the immune therapy is to be use as a primary therapy, and that all the sometime we using as a flat dose and sometime we using the per kg dose. The both are the equal fraction, but immune therapies are very costly. So most of condition, so if that patient using the per kg dose and sometime is to be dose will be count as a low and the packing dose is to be more, but immune therapy is good for the effectiveness, so we using the flat dose most of time, so dose will be not wasting. Okay, so we know about, I think, what are the mechanism, what are the agent and what are the toxicity, and the some topic like the cancer vaccines and CAR T cell therapy we discuss about in later classes. Thank you.